consent excretion. You're going to assess the client. Kidney functioning. How are we going to assess that?
BUN creatinine.
BUN and creatinine.
Yeah.
What do you know about BUN and creatinine?
You're gonna check their
Levels.
yeah. If
You
they're
don't really have to know this.
underproducing or over.
The levels for a newborn and all of that, infant and child, but I'm just going to holler out some numbers. 4 to 18, BUN for the newborn. 5 to 18 for infant and child. You don't have to know these. I just want to make you aware. Creatinine is like 0.2 to 0.4 for the infant, 0.3 to 0.7 for the child, and the adolescent 0.5 to 1. 7% of our infant and young children are prone to developing UTIs, urinary tract infections. They say about Escherichia coli is the pathogen for about 83% of our UTIs. Why do our females develop it more so than our, well, let me, shorter urethra, and so the pathway for organisms, but let me say that again. 83% of females usually have bacteria UTIs and 50% of males. So I said that wrong. Okay. All right, let's get started talking about other stuff. Focus assessment, urinalysis, UA, or urinalysis. Looking for what? Bacteria, white blood cells being present, blood, protein, ketones, all of that being present there. Then we are drawing serum and checking our what BUN, creatinine levels as well. May do a renal or bladder ultrasound, testicular ultrasound, cystourethropathy, imaging studies with contrast. May have to do a intravenous polygraphy. Intravenous polygram, see if they're allergic to iodine, right? They do a computed tomography, a CT scan as well. Need to know the child's history, family's history. If they have any kidney disease problems, things like that. What is the child's history and all of that. So prepare the infant and the child, parents for tests. Careful intake and output, and when I say careful, I guess we mean strict. Monitoring the blood pressure. Rarely see blood pressure problems in children and or infants, but we may. May do a careful collection of urine, can be anywhere from a 12 to 24-hour urine for creatinine clearance. Tell me, how will you collect a 24-hour urine specimen?
They would pee first, and then you would start from that moment after the first void.
Okay. What's important about collecting 24-hour urine?
Keeping it on ice, or you never throw away.
Discard the very first, and then we start from the time of the date, right?
Yeah.
Okay. So that's very, very important. There.
I thought the time doesn't start from the one you discard.
The one that you, yeah, the one. But discard the very first, and then now the 24-hour urine begins. Everybody understand how to collect the 24-hour urine? If you don't, you might want to read it before Friday. Okay. So UTIs, infections, we pretty much already said this. The reason why. Incontinence in a toilet-trained child can be a sign and symptom of why. They have strong smelling urine. They're complaining about they have to go often, so frequency and urgency. They may have some nausea and vomiting, abdominal pain. Want to eliminate the infection. Definitely want to prevent any systemic infection from developing. So you're probably going to have to put them on some type of antibiotics, right? Glomerulonephritis, inflammation of what? The glomerulus of the kidney, and nephrotic syndrome is what? Protein albumin spilling. So hypoalbuminemia, hypoproteinemia. May have to get an albumin infusion. We'll go over those in detail. You will have to see that you will see both of those again. Treatment, what are some factors here? They could have some vesicorectal reflux, we used to have to do a VCU. They do a vesicular urethrogram on the client, and so we insert a feeding tube as a Foley catheter, temporary catheter, because they're coming in with repetitive of UTIs. So now they may have a backflow of urine or the residual. They're not emptying the bladder, right, completely. And so they can do that in X-ray. They inject some type of dye to see things like that, and find out the reason why. Because the stasis of urine, that's why they tell us to go to the bathroom when you feel the urge, right? Because the stasis of urine remaining in the bladder is a area for what bacteria can go there and can lead you, and you may develop UTIs. So careful collection of specimens for infants and toddlers. Yeah, infants and toddlers. How do we collect a urine specimen? We can put cotton balls in the diaper at bedtime. And what else can we do? Urine bag. Place a UA bag. We can do, the febrile infant that's coming in, or febrile child. An infant is what? Well, a neonate is what age? From birth to what? 1 month? And then from 1 month to what is a infant? 12. Okay. And from 12 to what is what?
To 3.
Is it toddler?
Mm-hmm.
I still feel like my 6-year-old, 7-year-old toddler.
No, 5 feet.
8-year-old toddler, 9-year-old.
I can't hear you that.
What'd you say, Star?
Y'all know the age groups. When we say neonate, that's to 1 month. Infancy is what? 1 month,
1 month
to what?
to a year.
1 year. 1 year to what?
3.
3 is what?
Toddler.
Toddler,
3
pretty
to
much.
5.
3 to 5, preschool. Okay, so
Yeah.
understanding the ages makes a difference, in how you're going to collect the specimens, right? Because I can tell if we want to just get a clean catch midstream, who can I give that? Who can I teach that?
A potty trained child.
What?
Preschool.
Not a preschool, a clean catch midstream. Wipe from front to back, and that's in the middle of the year. Maybe school age, but definitely adolescent, right? We probably have to do the doctor really, like if somebody's coming in febrile and things like that, and they're really ill, the best specimen is an in and out catheterization. It's sterile. You don't have to worry about stool mixing in. You just, So that's the best. And you don't want false positive results, and you're treating someone, and that's and not actually what's really present, in their body as well. So be mindful of that. And so everybody pretty much know, on and on, older kids, we may have to do it in and out, or they may try to get a clean catch on the school age, maybe. Probably have to do it in and out on the preschool. I just doubt, to get a good specimen, get that best specimen, because they're just going to be upset and crying and things like that just for coming to the hospital, because they view that as punishment and things like that. So you probably need another nurse to assist you doing that in and out catheterization. So nephrotic syndrome, you got to know, you got to be able, and you all have been lectured on this, I was told, but you got to be able to differentiate what is nephrotic syndrome and what is what. What's the other one? All right, I guess we'll just continue on, and you'll know in a minute probably what. So the patho here, the glomerular permeability to plasma protein equals urinary protein loss. Says who does it affect? It says 2 to 7 years of age, children. Less than 1 year of age, 6 months of age to less than 1 year is rare, and it's unusual after 8 years of age. So that 2 to 7 is really kind of definitive. That's the age there that we see this. So we see proteinuria, right? Yes. What else do we see? Facial edema, periorbital edema. So around the eyes. May see more edema when they are rising early in the morning. Ascites, right? May have some type of pleural effusion. They may have some labia or scrotal swelling. You may see some ankle, leg swelling. The blood pressure is usually normal with nephrotic syndrome, but it can decrease, be a little low as well. But it's usually normal. That's a big difference in doing acute glomerulonephritis. You see hypertension, right? You see maybe mild to severe hypertension. So the blood pressure goes up with acute glomerulonephritis, but the blood pressure is usually normal and decreased. And usually with acute glomerulonephritis, probably 10 to 21 days after a streptococcal infection, they develop the acute glomerulonephritis, right? Okay, so we're not looking at strep here with the nephrotic syndrome. You got to know the difference. And in order, some of the symptoms are kind of like similar, but you got to know the difference. So pallor, fatigue, weight gain, decreased urine output, loss of appetite, and irritability. And so they have the massive protein urea, which therefore causes the hypoalbuminemia. Sometimes they may have to get albumin intravenous on the floor. And we treat it just like a blood product. They may have hyperlipidemia. And they may have a high platelet count. Have a good description in your book if you just want to look at that chart. It shows how you have the increase in ADH, they have the decrease in the protein, decrease in fluid retention. We treat them with corticosteroids. That's medication of choice. Start out with 2 milligrams per kilogram per day in divided doses for approximately 6 weeks. And then we always taper with our steroids, right?
Yes.
So then for another 6 weeks, every other day, we may give 1.5 milligrams per kilogram for another 6 weeks. This is according to your book. Our slide might be off a little bit and need to be updated. But that's from your book. So first 6 weeks, 2 milligrams per kilogram. Body weight. The next 6 weeks, decrease it to what? 1.5 milligram per kilogram, but every other day. That's the difference, right? What is that steroid? What's the side effects from the steroid?
Weight gain.
Weight gain.
Sugar.
Yeah.
Glucose, high sugar.
Maybe have hypoglycemia.
Immune system.
What'd you say now?
Decreased immune system.
Decreased immune system. Very good. So what do you tell Mom?
Wash your hands.
Wash your hands. What else?
Stay away from sick children.
Large crowds. Okay, very good. So y'all already know all that. We can keep moving, right?
Mm-hmm.
Sounds good, I tell you. Feels good. Low sodium diet. Sometimes acute, they say they may have some acute infection, so the physician may or may not put them on an antibiotic. Okay? They may get 25% albumin infusion, okay, intravenously. We probably do that over like 4 hours or more for the hypoalbuminemia. We need to replace that, right? So this would be a strict intake and output client, right? This would be a daily weight client. Right here. Pretty much says it all there. Don't have. And so with that, usually are better in 1 to 3 weeks. That may be so, but what do we say? We said for the first 6 weeks, so go by your book because it's updated. That's what we're going with right now. Disregard, I mean, it may be, but, you will see something similar to this, this information in some type of scenario, possibly, I'll make the changes if it's, because I know you all will make the changes too if necessary, so, after the test. And that's good critical thinking, I don't blame you. I was, Miss Hosey, I don't like that. Yeah. Like, what?
Oh man.
I looked. No. So I argued the point, right? Look at that question, read the rationale. Thought about Miss Lou, and she was saying, Miss Hosey, but yeah. And a couple other people, and I was like,
she said, "What's the computer?"
It is what it is. Nothing you can do. So it was a good exam. So that means that you are really, really applied yourself and studied. When you can come back and find where. Which I know that's your ultimate goal. So y'all just like, ooh. Yeah. I don't know, maybe we need to ring a bell and say, time is up. No more. You can't test it. So weighted wet pads and or diapers. Assess for the edema. Saying everything all over again. Say all that no more. Avoidance of infection. So, you know, that can be said any kind of way, but then you got to answer the question accordingly. We said avoidance of infection, so that could be one of your choices. I don't know. So, medications, we've said what the medications are. We've identified some of the side effects from the medications. So, you know, you just gotta, you gotta study. You gotta study. You gotta know. And you can get nephrotic syndrome confused with acute glomerulonephritis. I mean, especially if I'm testing, my mind is just like, yeah. And so you can get them confused. And it's easy, you know. It's a little, you know. Not really that much. No, it really ain't that much comparisons. No, you should be able to differentiate. So we got nephrotic syndrome. We can answer those questions there on excretion. Routine home monitoring of the urine protein dipstick. 2/3 of children do relapse. So you want to catch it early. Acute glomerulonephritis. Tell me what that is.
It starts in the kidneys. Inflammation of the glomerular.
Kidney. Post-strep throat. The book says 10 to 21 days later. Usually have had group A, beta hemolytic streptococcal, we just got through talking about under oxygenation. And then it leads to acute glomerulonephritis. May go from minimal to severe. You have complexes are deposited in the glomerular basement membrane. Therefore, they have edema, so they do have a little bit of periorbital edema, you know, just like the other. May have some facial edema. Kind of anorexic there as well. They have smoky brown or tea or cola color urine. Smoky brown tea or cola colored urine. Kind of lethargic. They're irritable. Dysuria. They have mild to severe increase in blood pressure. So how do you describe the blood pressure for nephrotic syndrome?
High.
Nephrotic syndrome.
Oh, nephrotic low. Normal to low.
Okay.
Sorry.
And so mild to severe, right? Okay, so here you may see a blood pressure problem. It's probably one of the only other times here and with a child who has some heart condition. We generally don't have, you know, you don't see hypertension problems with children. It's very rare. Usually CHF is the underlying diagnosis on a baby. And they may have acute glomerulonephritis. I've rarely had to treat or take care of a child with hypertension, per se, which is great. So pallor, they may have. What's I got there? Other signs and symptoms. So that's right there. Hypertension. And so the ASO titer. It's the one for the swabbing for the group A, hemolytic streptococcal infection. Proteinuria and hematuria, but not as evident like nephrotic syndrome. So they have gross hematuria, so 3+ to 4+. Hypocalcemia, hyperphosphatemia, and hyperkalemia.
So this one, hypo.
Hyperkalemia.
Okay.
Treatment is similar to nephrotic syndrome. The acute phase is unpredictable. So this child will be on some type of antihypertensive medication, diuretic, just do a little bit of Lasix, regular diet, no added salt. Appetite is pretty much generally poor, and they definitely want and require frequent rest periods. So if they have a normal blood pressure and normal urine output, they can be treated at home. The reason for admission is due to hypertension, the edema, and the hematuria. And also they may even have oliguria. So now they're hospitalized. We may have some moderate sodium retention. So we make some dietary changes there while they're in the hospital. And due to that hyperkalemia, that leads to that oliguria. So daily weights, We're assessing their vital signs. They said make sure you're monitoring that blood pressure very closely. The book says every 4 to 6 hours. It just depends. You may do it every 2 to 4. It just depends. Because we're going to give that antihypertensive, so we expect to see some results. And so we're not seeing any results. Make sure your cuff is adequate size. You know, like the preschoolers, toddler, things like that. You probably put that cuff on the lower part of the leg. You can put it on the arm to the infants, but we do check it like that. But just make sure your cuff is adequate, because I've seen it several times where the cuff is inadequate and you have a false reading, and we're doing things that nobody doesn't have any blood pressure problems at all, but that cuff is too small, so now it makes it seem like. They can have some cerebral complications. So we want to make sure that we treat, take care of it as much as possible. Treat the hypertension, monitor that potassium, you know, either hypo or hyper. Hyper or hypo can lead to dysrhythmias. And they said they need to be on a heart monitor, things like that. We need to still be monitoring them closely. We don't want it to get to that level, right? And then, you know, signs and symptoms of hypocalcemia. Some things that we just got to look at. And so that's it, and that is the bulk of your exam for that. All those things that I just talked out of the exam.
Girl, why you gotta push it?
Do you have to know about what, baby? You know, really and truly, we have had questions on the, I don't think we have a question on that. But with the Wilms tumor, that was a good thing for you to identify abdominal mass. And it's an abdominal mass that's cancerous, and that it is non-palpable. So that's great that she said that, because really and truly you may have that for NCLEX, but I don't know why we don't have, I don't think we do, but the main thing with that, you know, they are administered chemotherapeutic medication intravenously. Rarely do they have, we definitely missing that slide. I don't know, it may be here, but it affects males mostly. Abdomen is very, very distended, you know, from that large mass. And it's definitely the key there, and red flag is to never palpate the abdomen. You can make the tumor, make the situation worse, or even cause metastasis. So that's with the Wilms tumor. Chemotherapy is the treatment. Prognosis is pretty good. It just depends, you know, on identifying it early on, getting the treatment. You know, according to the American Academy of Pediatric Cancers, there's a protocol for every cancer. So based on what they say and how we treat it and how it's staged, that's how we administer the medication. I need to look back. Sorry. All right. What is hypospadias? Your congenital disorders.
A malformation.
What is hypospadias?
It's not in the right place.
Okay, it's behind the glans. The urethra opening is behind the glans penis, right? What happens with the epispadias? The dorsal surface area there, the medial opening, and cryptorchism. What is that? Yeah, failure of one or both testes to descend normally through the inguinal canal. So just understanding the definition of those, you need to understand that, you need to know that. Okay? So how can we take care of those? We have to do surgery. Because we want, you know, adequate flow of urine, right? To exit properly for the child, for the male, you know, things like that. And so we prepare the children and the family. No tub baths times 1 week. Gonna look for signs and symptoms of infection, which we know. Surgical dressings, and address parental concerns regarding baby's future. Wilms tumor is next. I thought that was in here, but okay. And any type of restrictions that deemed necessary, just as written by the physician. You know, they're usually do well, heal properly, you know, not in the hospital long, you know, easy. They may even do a lot of those outpatient now. And so Wilms tumor, nephroblastoma, large tumor, kidney, malignant renal, intra-abdominal tumor of childhood, peak age about 3 years, may have a family history of cancer, malignancy, weight loss, size of the liver and spleen, very enlarged, anemia, and lymphadenopathy. So there's another one there, and I know pediatrician who did a conference in spring, he said, you know, generally we are not supposed to be able to palpate our lymph nodes. So here you do have, you know, palpable lymph nodes. And then he said with Hodgkin's, and so really most of the time there is an underlying cancer, but not all the time. Because he said infectious mononucleosis, you know, mastoiditis, and he gave a couple other things. So abdominal swelling mass is noted by ultrasound, CT scan, to do chemistry, urinalysis, and definitely have to do surgery. Hope is encapsulated. That's how we want to find most of our tumors, because that gives a greater indication that it will not metastasize. And I took care of a young man that really looks like this picture. No jokes, you know. So pretty serious.
Poor baby.
Pretty serious. So prognosis, about a 90% cure rate. We've had some to expire from it, but yeah, some will do well. That multimodal care, that chemotherapy and that radiation therapy, if they have to have that, and just, you know, having a great oncologist and knowing what to do is very, very important. And it kind of like does determine, you know, really and truly the longevity, you know, it really does. Do not palpate abdomen. That's a rule of thumb. I see that on NCLEX. Careful bathing and handling. Prepare the parents and the child. Keep it simple and repetitive. Vital signs, especially the blood pressure. What are some of the chemotherapeutic agents? Vincristine, give intravenously. Induced ileus. Healing is rapid. Radiation is as well. Since their GI activity post-surgically, bowel movements, bowel sounds, distension, vomiting, pain, blood pressure, urinary output. If there are any signs and symptoms of infection developing, and pulmonary hygiene. You know, once we start that chemotherapy, generally we kind of like become what? Immunosuppressed, white blood count goes down immediately, like a week after, the NADAR. So they're given that Neupogen or Epigen sometimes, you know, to boost that white blood count up. So now they're more susceptible at that time to develop things. So we have to be cautious. Parents are really educated. Oncologists really educate them on all of that. And the main thing for this child now is to the parents to bring him probably weekly, if not every other week, to get a pretty strong chemotherapy to treat the cancer. And then, you know, we'll do abdominal circumference on this child daily. Maybe do it every 4 hours after surgery. It just depends, even before surgery. But this is a client that would warrant abdominal circumference measurements to be accurate and all that. All right, hydrocele. Fluid in the scrotum, swollen testicle feels like a water balloon. Common in newborns. Normally goes away after a few months. I'll repeat it. Look at that picture very well. Fluid in the scrotum, swollen testicle, feels like a water balloon. Common in newborns. Normally go away after a few months. But it could be kind of like worrisome to the parents. Surgical repair is spontaneous resolution not accomplished by age 1 year. So we can see there a lot happens, you know, within 1 year of life for the child, for the baby. So these are medications that you might want to familiarize yourself with. Penicillins, what are they? Cephalosporins, considered safe. Most age group eliminated more slowly in neonates. Cephalosporins do enter our breast milk. We do need to tell moms or anyone to take it with food. And sometimes we may have to taper that dose or decrease that dose for a renal patient. Penicillin take mostly on an empty stomach. That's right there in your PowerPoint, what I just said.
So would that mean that you would have to pump and dump your breast milk?
Pardon me?
Would that mean you'd have to pump and dump?
Well, she can pump and freeze. She can freeze. She can freeze it. You saying immediately while she's doing this?
Will the cephalosporin enter the breast milk? Is that okay, or does she need to not breastfeed during that? Is that just a question for like a doctor?
Well, I guess she would possibly have to pump and dump. I mean, I've seen some that, you know, still, you know.
Save it, you can do other things with it.
Yeah, still, you know, saved it for later. It just depends, I guess, you know. I mean, and then it has to do with the time period that the cephalosporins probably enter the body and things like that. It just depends, yeah. But probably to be on the safe side, yeah, she probably would pump and dump, yeah. To be on the safe side, yeah. And I mean, that's the only thing you can do is educate her on it. We don't know if she's, you know,
gonna follow through with it or not. She might still do it.
Most people, I mean, most mothers probably not, unless they really understand, you know. So the first generation is the cephalosporins to treat our staph and streptococcal infections, not MRSA. We have our mycins, clindamycin, vancomycin, things like that that treat the MRSA. Keflex, dose for children. Then you have your second generation for Escherichia coli and Pneumococcus influenza. It may be on C-chlor or antibiotic, 20 to 40 milligrams per kilogram. And Omnicef is a very, very strong antibiotic, which is your third generation, IV, IM, and or ceftriaxone or rocephin can be used to use more for more resistant organisms. And then your fourth generation would be the Maxipine that can be given intravenous or IM. Just briefly read over these drugs there. Tetracycline or doxycycline is contraindicated in children younger than 8 years of age.
Yeah, some strong crap.
Is a long-term treatment for acne, chlamydia-type organisms, Helicobacter pylori, Lyme disease, syphilis, and many others. Been here for a long time. Avoid intense exposure to sunlight or sun lamps. And generally, those who have penicillin allergies are on doxycycline. You might substitute it for that. Tetracycline, no dairy products, antacids, or iron.
That's funny.
Doxycycline can be taken with or without food. Aztreonam or Azactam, it's another antibiotic. You'll see to treat a lot of UTI, skin infections, lower respiratory infections, some gynecologic infections. An advantage of it, it preserves the normal flora. So it does not kill the good bacteria in the process of treating the infection. It's the monobactums. And we know the Z-Pak or Zithromax or azithromycin treats a lot of gram-positive cocci, strep, pneumo, cephaloccocci, otitis media, pharyngitis, tonsillitis, Helicobacter pylori, with or without meals, and no antacid should be taken with it. And you know, we probably like take a dose. You know, the dose changes by day. It's about a 5-day dosage of that. And your fluoroquinolones or ciprofloxacin, usually to treat your UTI, respiratory, GI, soft tissue infections, and multi-drug resistance, tuberculosis, and anthrax. Contraindicated in children less than 18 years of age. Do not take with antacids, vitamins. Space out by several hours, and encourage fluids. We're going to talk about your corticosteroids pretty much. Read that there. Side effects of it. Concern for children is growth retardation. Parents can record their height and weight weekly. cosmetic changes and all that. Diuretics, manage your hypertension. They can be maybe one of the medications that can be given for acute glomerulonephritis, right, due to the hypertension, increase in blood pressure, heart failure, and edema from heart, kidney, liver. Increase urinary output, may lower the potassium. Need to take early in the day. May cause sensitivity to light. And may definitely do a daily weight, because that's kind of like how we understand and determine if our diuretics are really working well, right? Daily weights. Specific considerations when taken with digoxin can increase digoxin toxicity. So we want to be make sure we're aware of that. Related to diuretic-induced hypokalemia. And Lasix most often used in children. Generally never go above 6 milligrams per kilogram per day. Lasix or furosemide. And you would see furosemide and not Lasix. Sorry. And some of the anti-neoplastic agents, we kind of like said a few things, but just you can just look there. Nitrogen mustard is one of the most oldest drugs of choice of ancient. We give it kind of like not prophylactically, but palliative. You know, there's nothing else we can do for that type of cancer that we're treating for that child. You know. Cause a lot of major side effects. And something else. Cisplatin, used to treat cancers of the bladder, ovaries, and testes. Will cause some nephrotoxicity, nausea, and vomiting. So with a lot of these medications, we strict intake and output. We probably have IV hydration going on prior to. Like it says, give 3 liters of fluids. We do rehydrate the client with intravenous fluids. That Mesna and that leucovorin agent there, protective agent there are done as well. And carboplatin is used to treat endometrial and ovarian cancers. So, anti-neoplastics are not great, but they're great, because they definitely kill the cancer cell, kill the healthy cells as well, but the good outweighs the bad there. All right, observation and excretion. 5 minutes break. I thought we were going to have a little extra time, but not really. We'll go into immunity.
Yeah, she said take a 5-minute break.
5, 10.
She said 5, 10.
10 minutes is fine. I can talk.
I know, right?
They trust what you're telling them, so don't tell them, anything that's not true. Please tell them the truth about everything that's going on with them. They may not want you as their nurse anymore, and they will verbalize that. So be careful. So what is systemic desensitization? By allowing a small child to play with the equipment on doll, OR, or by participating in actual procedure, desensitizes their anxiety and makes them a better person, or takes their mind off of what is actually beginning to happen, and allows you to be able to facilitate and take good care of them and do your head-to-toe assessment, or maybe give the injection, or maybe give the medicine to the doll first and then give it to them. And it's just a lot of things you have to do as a pediatric nurse, right? Yeah. Have the stickers with you, have treats, you're checking your pockets and things like that. So kids are fun. So juvenile idiopathic arthritis, what is that? Autoimmune disease. Affects the joints of the hands, arms, and legs. Inflammation, which causes pain. Red, warm, causes stiffness. So what happens, white blood cells loses the ability to tell the difference between the body's own healthy cells and harmful invaders. Can affect anywhere between 6 months and 16 years of age. They may have splenomegaly, increased fever, rash, and enlarged lymph nodes or lymphadenopathy. It affects joints on both sides equally. May initially begin in a couple of joints only, or most frequently attacks the wrist, the hand, the elbow, the shoulders, the knees, and ankles. What kind of labs do we need? Might need to do an estimated sedimentation rate. Whenever we're checking your C-reactive protein, CRP, or estimated sedimentation rate, if it is elevated, that's pretty much indicative of infection somewhere in the body, in the system, wherever. Then we do a CBC. The ANA, just how rapidly red blood cells settle to the bottom of the test tube. The red blood cells rapidly settle on people when inflammation is occurring in the body. So those are some labs that we may have to do for the juvenile idiopathic arthritis. Identify the areas that will be affected. We said that pain is an issue, discomfort, edema, inflammation. So physical therapy is definitely needed to help keep joints flexible and maintain range of motion and muscle tone. Get regular exercise. Can participate in sports based on the physician's recommendations. Decreased weight bearing on the joints can lead to osteoporosis. So how do we treat it? Warm hot packs. And it have adequate calcium intake nutritionally. Avoid flare-ups as much as possible. Get rest. Control side effects of medications. And promote improved mobility. What are some medications that we can give?
DMARDs, NSAIDs, and corticosteroids.
NSAIDs. Methotrexate may be given sometimes, which is a chemotherapeutic agent. Maybe in some of the more severe cases. Corticosteroids we definitely going to try there as well. We want to slow the progression of the rheumatoid arthritis. We may give Rheumotrex, methotrexate, and Trexol. Safe for long-term use in children, but it can cause some nausea, vomiting, and diarrhea. We use methotrexate intravenously for some other cancers, and it does cause nausea, vomiting, diarrhea. So we do give them the antiemetic Zofran prior to administration. Can be toxic to the liver, bone marrow, and it can affect the immune system, therefore putting the client at increased risk for infection, right? So they become immunosuppressed. So naproxen can be used widely, most widely used. Also treats pain and fever. They may have hepatotoxicity, most common in aspirin use. Monitor labs every 6 months. You know, we try not to steer away from aspirin as much as we can due to the Reye syndrome. And renally, we may have some toxicities there, acute renal failure, or nephrotic syndrome, salt and water retention. It may inhibit platelet aggregation. So rule of thumb for the pediatric patient, always use the lowest effective dose. We always try to use the lowest effective dose in any medication, especially with our corticosteroids. We already went over some of the side effects. We can go again, but you know, some of those already. Anti-inflammatory, immunosuppressant, to treat the autoimmune disorder. So it definitely said increase in weight, increased appetite, so we're eating more, increased blood sugar, and there's already identified hyperglycemia, mood swings, headache, fluid retention, increase in blood pressure. Long-term use of this corticosteroid, which they may have to use it, you know, forever. Decreased immunity, increased cholesterol level, definitely the weight gain, may lead to osteoporosis, stunts the growth and thinning of the skin, and deposits of body fat. So it causes salt and water retention, therefore it causes the weight gain with the increased blood pressure. I want you to eat a diet low in sodium and increased in potassium. Reduce sensitivity to insulin, therefore it increases your blood sugar. And then it causes protein breakdown in the muscles, so you get the thinning of the skin and all of that. Then you have the hyperlipidemia, because it redistributes carbs, fats, and proteins. So, hyperlipidemia from that. inhibits your linear growth by decreasing the release of the growth hormone. Muscle wasting, secondary to protein catabolism. Always tapering the doses, removing from medications. So juvenile rheumatoid arthritis, let me see 1 or 2 questions on that, just make sure you're all aware of that. HIV, AIDS, is there anything we need to really just say? How prevalent is it with our children, with our newborn babies? What are we seeing? 90% perinatally. Retrovirus is pretty much in the lymphocytes and the monocytes. Said that there was a peak in 1992, but since then it has been a decrease in seeing it perinatally or even in our children. And one of the #1 reasons was counseling and the antiretroviral therapy to prevent perinatal transmission of the medications being used there. The nucleoside analog reverse transcriptase inhibitors are really working very, very effectively to help treat the HIV in the pregnant woman, and therefore not transmitting to the fetus as much. But HIV can be found in the semen, in the vaginal secretions, and breast milk. So be mindful of that, that it can be present there, so she will not be able to breastfeed. Look at that CD4 level, the lymphocyte count, and the viral load. We see a lot of our children from ages 3 to 6 months with pneumocystitis carinii, pneumonia. They say that they rather children who have been exposed and are infected with AIDS to not get the pneumococcal or the flu vaccine. If they don't really have if they have severe immunocompromise, meaning they're not immunosuppressed, they're saying that they can possibly get the MMR and the varicella vaccines. They say that they can go to daycare, to schools. We just got to educate, teach, according to the Center of Disease of Control, standard precautions. They do experience a lot of pain. They have a lot of ear infections, otitis media, dental abscesses, and things like that. Those children that are affected with AIDS from birth. Not everyone, because the mother has AIDS, that does not mean that the baby will too. We've had a few incidents where the baby never did. They kind of like say still, we kind of monitor them up to 1 year of age, drawing blood and checking, their CD4 level and things like that, because things can change. We know that with growth and development, and maybe they're not showing any signs right now and they're just negative, but yeah, they can even become positive. So HIV progression is more aggressive in children than in adults, and we already said they have an immune system is not strong enough, right, to handle anything. So definitely not HIV at all. And can I be vaccinated against HIV? No. So we have a high percentage if the mother is already positive with HIV. So poor nutrition, increased nutrition needs, results of malabsorption. They have the impaired immune system and increased vulnerability to infections just all the time, in and out of the hospital, having to be treated. May have increased vulnerability to developing tuberculosis, diarrhea. So we definitely do that T-cell measurement via the CD4 test, the viral load. Sometimes they tell us that the HIV antibody test is unreliable, less than 18 months of age. A decreased T-cell count is equivalent to an increase in the disease progression. A decreased T-cell count. In the United States, treatment is recommended regardless. And there are 2 to 3 medications that we try to administer. Comes in elixirs for the babies that we give them. The Retrovir, another one. So So there are a minimum of 3 drugs as prevents HIV from becoming resistant to one drug. So we have to give these medications in combination with others to try to treat this. You can just be given one medication and that's enough to take care of this. It's up to about 3 of them. 3 I know. Pretty much gave like 2 Retrovir and the other one Zytodyne, I think, to the babies. We pretty much will give those. Yeah, you got to do them on time, around the clock, as scheduled, as ordered by the physician. Treatment is based on stage and the progression of the disease from stage 1 through stage 4. The goal is to slow the growth of the virus, to prevent it, to treat the opportunistic infection, providing nutritional support and symptomatic treatment. We want to educate the parents on transmission and everyone, because there are many myths about HIV. And so we have to educate everyone. Found in blood, body fluids, semen.
Is it a page behind? Is it a page behind the screen?
Pardon me?
Didn't you just already read all this? But then you're
I did. I read
okay,
that.
you're on a different slide. Okay.
I read that, and I'm just letting you guys know if you want to write it. And I just read that too. Miss Dimson, what you trying to say? You ready to go?
No, I was
just making sure she wasn't off.
I think you already said that.
I know. Miss Alexander said. You tired of hearing my voice?
Ma'am, we're just trying to follow along.
I'm just messing with Dimson, chill. She's fine, no, I'm just messing. And that class wasn't supposed to laugh. I mean, really.
I'm chill.
Okay. Energy requirements increased by 10% in asymptomatic patients. This is a page that, all of it has some significance. Energy requirements are increased by 10% in asymptomatic patients, by 20 to 30% in symptomatic patients. Now, I'm not going to repeat that. Parents, protein should provide 10 to 12% of their total energy intake. They need vitamin A supplements. We encourage them to drink fluids to stay hydrated, preferably those that will help with electrolyte replacement. And you guys know what those are. Anorexic give preferred foods, high energy foods, small frequent meals. Fluids and energy dense foods to give to them when they're febrile. Sunlight at least 10 minutes per day. They need calcium rich foods such as yogurt, milk, soy products. Pain management related to the diagnosis and therapeutic interventions. So we may need to have them on pain medication, around the clock in the hospital. They may even still have a standard medication that they take at home. Pain is pretty bad, especially as the stages advance. They're in a lot of pain. Side effects of therapies: oral cavity, esophagus, abdomen, and neuromuscular. Some of the areas where they may have side effects of some of the treatment that they've received there. So anti-metabolites. They can interfere with one or more enzymes or their reactions that are necessary for DNA synthesis. And we look at our anti-folate. Pretty much interferes with the use of folic acid. Then we have our anti-retroviral, as I said, the AZT, Zytodyne. That's one of the #1 medications I know that we administer to our babies. It's treated with the 2-nucleoside reverse transcriptase, as I had said, inhibitor. And then we treat it with the 1 non-nucleoside reverse transcriptase inhibitor, which is an enzyme, the virapine, or capital N, capital V, capital P. So those are the 2 medications that we are giving these babies here. faithfully. Adult patients could be up to another medication added to that, so it can be up to 3 medications that we're having to take. You know, periodically coming in to check their viral load and everything there, CD4 count, things like that. So have not been tested in the pediatric group and not available in pediatric formulations. No pediatric doses, but I just want you to know that yes, we are administering AZT and the nevirapine to our pediatric patients in combination together in order to combat this HIV virus. And the dose is computed based on their body surface area and weight in kilograms. Very expensive medication and very does not have great taste to it. We do not mix them with any type of elixirs or anything like that. We don't know about anything, syrups or anything taking away the potency, but we don't want to take that chance. So you have to make sure, tell the mom, you know, the parents, you got to make sure this, you know, child gets this medication. And we do know that, you know, individuals with HIV/AIDS are living longer and living healthy, productive lives due to the, and it's a new medication out, you all probably know, did y'all get it in med-surg, an oral tablet that they can take now, and it's really, they're seeing great prognosis with it to help treat, you know, AIDS as well, and possibly even cure. I wish I could holler the name off, but we went to a conference, I think, in the spring, and that was my first knowledge of even knowing about it. I'm not sure how long it's been in the United States, and you know, where are we using it, or prevalent, or how expensive it is. But there is a medication out that to treat HIV for them. So protease inhibitors are the second line of treatment, and enzyme inhibitors. Most are hepatotoxic, causing increased hepatomegaly, problems with your liver enzyme, enzymes, AZT, ALT, can cause anemia and neutropenia, and they need to stay on a regimen for 24 weeks before switching to anything else. This last chart is really identifying that the norms of the norms of respiratory rate, hemoglobin, things like that. Don't just keep that in stone and try to remember that, but it's just and other lab values there. And we talked about the ESR, estimated sedimentation rate, and say whenever that's high, or your C-reactive protein, either or, there's probably generally some infection present. Infants and children have a faster respiratory rate because of increased metabolic rate and need for oxygen. Is the calcium number there. So how do we take care of these immunocompromised children? Wash our hands, follow standard precautions, treat them the same as anyone else, don't make a difference. Follow strict asepsis for invasive procedures. Avoid contact with persons with infectious disorders. Avoid immunizations with live vaccines for patients, siblings, and family members. Monitor their food and other items entering the room as well. All right, any questions about all day today?
So the 2 main drugs that you said we need to know is the we got one that last slide.
Right, for AIDS.
AZT and NVT. Those 2.
We talked about how to treat rheumatoid arthritis.
Then,
And you said we
if she wants you to do that, the chain of command, it's her and then Gary. What did she say?
The diet of the HIV person, you might want to review that. Protein and all that for the HIV fine. Anything about today's nature? What you got, about 35 questions of information. And you got 5 on Friday.
Oh, okay.
So you're at 40, well, no, 30 today and 5 on Friday, May 31st, so 15 tomorrow. And that should do it. So we do cognition, mobility, and integrity, right?
Yes, ma'am.
So that should not be that bad. Cognition, those 3. I'll see you guys. What time is it? Y'all ready? Okay.
Like Wednesday morning.
And they say it's very cold outside.
Why? Can we start class? Yeah, tomorrow morning. You want to do tomorrow morning? And we have 2 hours tomorrow morning before class. Yeah, but we have 2 hours tomorrow morning.
Did she say anything back to you? Oh.
Mine don't start until she can tell them. What do you know? Because Miss Campbell keeps us updated.
Right.
Miss Campbell's
This
about
has to
that.
go up to the chain of command.
She's